I am Professor Jaydip Ray. I'm the Clinical Director for ENT at Royal Hallamshire Hospital, Sheffield. Today we'll talk about the management of some common balance disorders, both their assessment and treatment, particularly benign paroxysmal positional vertigo, or BPPV as it's commonly called. So patients with balance problems usually come with a conglomeration of symptoms, which is often difficult to tease out. The most important thing to find out from them is whether they are having intermittent rotatory vertigo or persistent imbalance. If your patient is mentioning intermittent rotatory vertigo, it would be most important to find out the precipitating factors, relieving factors, and any positional element to them. There may also be dietary elements as well as other precipitating factors that you may not have asked for, but the patient might volunteer, like injuries, etc., which are of very recent occurrence. Following that, it would be important to find out a periodicity to these episodes, i.e., are they coming in clusters or are they coming in due to specific events. They may also be associated with other symptoms, which might be nausea, vomiting, hearing loss, fluctuation in hearing, or tinnitus, or a fullness or pressure in the ears, which might give you an indicator as to the type of balance disorder it is. Moving on to positional vertigo, or BPPV, the classic presentation is that of a sudden onset of a spinning sensation brought on by a movement or acquiring of a position of the head relative to the body, which may be either whilst lying down or rolling over in bed to a particular side. There is usually a short latent period, and that may vary from a few seconds to about 10 seconds. The patient feels a sudden onset of a spinning sensation, which may or may not have a nauseous component to it. The whole symptom complex will pass in about 30 seconds to 40 seconds, and the patient is usually asymptomatic between the spells. However, the symptoms recur every time the patient resumes that position or moves once again, which they find extremely disconcerting. Following a detailed and structured history taking, once you have arrived at a diagnosis of benign positional paroxysmal vertigo, you would want to assess the patient to confirm the diagnosis. And the classic way to confirm the diagnosis is what is known as the Dix-Hallpike maneuver. This is done by having the patient sitting up midway in a couch facing away from the tester. The tester sits behind the patient such that when the patient lies down, the head is slightly off the edge of the bed and supported by the tester's hands. One would start off doing the test with the better ear, i.e., you would want to turn the patient's head to the unaffected side by about 45 degrees. Once the patient's head is turned to 45 degrees, you would also presumably explain to the patient what you're going to do, explain that their head will be slightly off the back of the couch and that you will be supporting the head and the head won't be falling off. You would also be telling them that they might go very dizzy, and should they go very dizzy, not to panic, as this would pass very shortly, so that they don't try to jump off the bed. It would be important to ascertain whether the patient has got any neck, back, or spinal problems or any severe neck stiffness, so that they do not experience any pain or injuries during the testing. It would be useful to have a chaperone or a nurse to help you, but it's not absolutely necessary, as you can use the patient's relative or accompanying person to help you. So having done all that, the tester is sat at the end of the couch, head end of the couch, and the patient is sat up facing forwards. The head is turned to the right side in this case, as the patient has a left-sided symptomatology, in that they experience the spinning sensations when they lie down and turn over to the left. So the head is turned to the right side. The tester is supporting the head and requests the patient to lie down rapidly so that the head is off the edge of the bed is about 30 degrees below the horizontal level. At that point, it would be important to observe the eyes for nystagmus, which is an involuntary saccadic movement of the eyeballs. Now, in case of BPPV, if it is positive, one would observe a torsional nystagmus, which is geotropic in nature in its classic description, i.e. the nystagmus would go to the undermost ear, which is the affected ear. This usually has a small latency period of 10 to 20 seconds, lasts for about 40 seconds, is directional as I described towards the undermost and affected ear, and then slowly disappears after that period, and the patient's symptoms also start to settle down by then. It is important to differentiate this nystagmus from central nystagmus, which has no latency period and it starts immediately, can have any direction as it chooses to, and is not fatigued by repeating the test. Once the nystagmus and the symptoms settle down, then you might either want to proceed to an Epley's maneuver or test the other side. So in this case, the left ear is the affected ear. So what we will demonstrate for you now is how to perform an Epley's maneuver for the left side. So with the patient's head supported on your hands, with the head dependent at 30 degrees from the horizontal, or with it turned towards the left, you would try and achieve a rotation of about 180 degrees from left to right, having warned the patient that you're going to do it at the count of 1, 2, 3, so that they can keep the neck and the head relaxed. Whilst doing that, they will also experience significant dizziness and nausea, so it's well worth warning them about this and preparing yourself for the eventuality as well. Once the head has been turned from left to right by 180 degrees, the patient would bodily roll over to the right side such that they have turned to their right and the head is facing somewhat downwards towards the floor at about 45 degrees, looking down on the floor on the right hand side. Once this is completed, the patient is then assisted to sit up on their side and clear the bed so that they're sitting up now on the opposite side of to the right side of the bed with their legs hanging from the right side. It would be worthwhile helping them off the couch because they may well still be dizzy, and it's worthwhile checking that they're not dizzy before letting them home. Some routinely advise patients to try sleep slightly propped up for the next 3 weeks and avoid turning over to the affected side for that duration, although there is no strong evidence to support this. However, it may well benefit them to observe some restrictions. The maneuver is successful in about 85% of patients, but may well need repeating and can safely be repeated if symptoms fail to respond or if symptoms recur, and the procedure is exactly the same each time. For patients who have a lot of neck stiffness or are phobic about having their head hanging off the edge of the bed and in a head dependent position, but with symptoms suggestive of benign positional paroxysmal vertigo, one option might be to do a side lying test and a Simon's maneuver should it be positive. This is done with the patient sitting sideways on the examination couch and the tester facing the patient. Should the patient have a left-sided BPPV, as in this case, one would have their head turned to the right at about 45 degrees and ask the patient and assist the patient and ask the patient to lie down on to their left at a rapid pace. And should there be positive nystagmus, which will be dependent on towards the right, onto the left dependent ear, one would proceed to do the Simon's liberatory maneuver, i.e. moving them from the left dependent to the right dependent, but keeping the head turned to the right all the time. So effectively, you have your patient lying on their side on the left with the head turned to the right, and you help the patient to move through an arc of 180 degrees from left to right, but maintaining the right hand turn on the head.